Hi, my name's Roger Bourne, and I'm going to give you a bit of a rundown on our new MRM paper about diffusion anisotropy in prostate tissue studied ex vivo. So the background of this paper is the quite wide range of results found for clinical assessments of fractional anisotropy in prostate tissue. So from our introduction we mention that there's 9 clinical studies, 5 reported FA in cancer tissue to be higher than in normal tissue, 3 found no difference, and 1 study found cancer FA to be lower than normal. So a possible confound in these studies is that there are some actual structural differences between cancer and normal in different prostates, but maybe the artifacts and the limited SNR that we get in clinical diffusion measurements is masking these effects. So what we wanted to do was look at the pure structure, if you like, in the absence of perfusion effects, and look at how FA varies in the prostate. So first of all, I'll give you a bit of background. From 2012 we did some very high resolution diffusion imaging of prostate tissue samples with 40 microns isotropic resolution, and we see some nice diffusion contrast in these diffusion microimages. And the significant thing to note here is that if we look at the gland structure, we have low diffusivity in the epithelial cells lining the gland acini. We have intermediate diffusivity in the fibromuscular stroma and quite high diffusivity in the lumen of the glands and ducts. If we look at anisotropy on the same kind of spatial resolution, again 40 microns isotropic, we find that the maximum FA is actually fairly high, about 0.66, similar to what you'd see in heart muscle, say. And the orientation of the anisotropy, or the principal eigenvector of our diffusion tensors, matches up quite nicely with the orientation of the stromal myocytes. And if you do a bit of fiber tracking, you find that the fibers are confined to the stromal tissue, and we can see essentially low diffusion anisotropy in the epithelial cells lining the ducts, and naturally low anisotropy in the lumen space where we have fairly free diffusion. One thing to notice from these microimaging studies, if we look at a largish volume of tissue, and in this case we're looking at 3 different tissue cores that are about 3 millimeters diameter and 4 millimeters long each, we can see that although we have quite a high anisotropy on a small spatial scale, most of these tissue cores actually have quite a variety of fiber orientations within them, and each of these tissue cores is similar in size to 1 or 2 typical in vivo voxels. So although we have high anisotropy at high spatial resolution, it's quite likely that in clinical size voxels this kind of heterogeneity of the fiber orientation is going to reduce the apparent FA at that clinical resolution. So the questions we wanted to look at in this paper, where we studied 7 whole prostates ex vivo, does the anisotropy depend on voxel size because of this microscopic heterogeneity of the fiber orientation? And could the anisotropy, if it's significant, affect DWI contrast and ADC measurements? Now the reason for this question is that most ADC measurements are based on a 3 diffusion direction measurement, not a 6 direction measurement where we calculate a tensor and then the mean diffusivity. So if there is significant anisotropy, then a three-direction DWI measurement and an ADC calculation from that could actually be orientation dependent. So the way we do this experiment is to get prostates immediately after surgery. We looked at 3 of these fresh, and then later on after fixation we imaged them in a 9.4T Bruker scanner, use a PGSE method, diffusion time about 18 milliseconds, and for this particular DTI measurement a B value of 1600 seconds per millimeter squared. And you can see an example of a prostate here. It's been inked, the seminal vesicles removed, and we suspend the prostate on a 5mm NMR tube filled with saline. That saline gives us a nice reference to the diffusion standard. So why are we looking at prostates ex vivo? Well, we can eliminate the perfusion and patient movement effects and focus our study on the tissue structure. Now, there's possible changes in tissue structure because of that lack of perfusion, but our argument is that if we can't see significant diffusion differences under these ideal ex vivo conditions, then there's probably no point in chasing them in vivo scans. And the other nice thing about the ex vivo scans, apart from being relatively cheap to perform, we get very good quality data with very high SNR. So the results from this study, here's an example comparing 3 prostates that were imaged before fixation and then again after fixation. We can see that there's quite a bit of heterogeneity in the anisotropy, or the direction of the principal eigenvector of the diffusion tensor within each prostate, and we can see that this is not very significantly changed by the process of fixation, even though the shape of the prostate does change somewhat. It's interesting to note here that the amount of change varies from prostate to prostate. So in prostate 1 and 3 here, we don't see a lot of change in the shape of the prostate, but in prostate 2 there was quite a big difference in the shape of the organ before and after fixation. We're not sure about the cause of this, but it probably relates to the kind of connective tissue and the stromal fiber orientation within that prostate. And if we look at the mean anisotropy, or the mean voxel anisotropy throughout the prostate, that decreases by about 0.05 to 0.08 due to fixation. Okay, so in figure 4 of our paper, we illustrate the mean intraprostatic voxel anisotropy versus the size of the voxels. So we took the native voxels from our data sets and then just added them progressively pairwise to generate progressively larger voxels, and then looked at the mean FA as we increase the voxel size. So the interesting thing to note here is that in all 7 prostates, the mean FA decreases more or less linearly as the voxel volume, or the log of the voxel volume, increases. So this is quite consistent with the idea that we've got heterogeneity on a microscopic scale, and as we go up in voxel size, this heterogeneity leads to a continuous averaging and a decrease in the overall FA. The other thing to notice about this particular figure is that we have very big differences in FA between the different prostates. So this suggests that using a single FA value as any kind of diagnostic marker would be very hazardous. If we look at one particular prostate and how the FA changes as the voxel size increases, we see that if we start with the smallest voxel size, 0.125 millimeters cubed in this case, the average FA is about 0.4 to 0.5. The maximum we can see here is about 0.8. You'd have to wonder whether some of those high values were due to noise. If we start to go up in voxel size, the average FA and the maximum FA both decrease until we get down to this grey shaded area, which represents the typical size found in clinical imaging. We can see that the maximum FA is around 0.5 and the average is actually quite low, around 0.2 to 0.3. So another way to illustrate this change in FA as the voxel size increases, here we show the orientation of the principal eigenvector at 4 different spatial resolutions. So at high resolution we can see quite a lot of heterogeneity throughout the prostate. As we go up in voxel size, we can see this heterogeneity starts to disappear, and we get a lot of averaging out, a loss of that anisotropy information that's present on the high spatial resolution scale. One point to note about this particular diagram is that as we go up in voxel size here, I've brightened the image so the FA values are actually going down, but I've enhanced the brightness here to focus on the loss of information and also the loss of detail in terms of the eigenvector orientations. Now in one prostate we looked at the effect of the diffusion time. Diffusion time is a factor that's often neglected in DWI studies. So basically the diffusion time affects the spatial scale sensitivity of the measurement. So it's quite plausible that depending on the size of the structures that are causing the anisotropy, that we would get differences in the measured anisotropy depending on the diffusion time. So we looked at how the FA changed, or the average FA throughout one prostate as the diffusion time increased. So at high spatial resolution we can see that the average FA actually decreases as we increase our diffusion time, and this effect is less pronounced at the larger voxel sizes. So again, for clinical size voxels, roughly in this range, a little below 16 millimeters cubed, we could expect a small dependence of the observed FA on the actual diffusion time. Now, we couldn't look at the relationship between anisotropy and pathology in detail for 2 reasons. We've only got 7 prostates. Only a small set of those prostates had distinct pathology that we could match to the MR images, and the matching of the MR images to the actual pathology is a difficult business at the best of times, so we didn't attempt any kind of quantitative correlation of FA with pathology. But here you see the 4 prostates where we do have some reasonably distinct pathology, Gleason patterns 3 and 4 in this case, and the corresponding FA maps in roughly the same slice of the prostate. The notable thing here is that qualitatively we don't see any kind of distinct FA difference between the normal tissue and the Gleason pattern 3 and 4 tissue. So in summary, diffusion anisotropy measured by FA from a simple DTI measurement, a 6-direction measurement in our case, decreases as voxel volume increases. There are big FA differences between different prostates, even at the same voxel volume. The FA doesn't show any qualitative changes with tissue pathology in the small number of samples we looked at, and we only find high FA in a small fraction of all voxels in any particular prostate. So what are the clinical implications of this study? Well, it seems that simple DTI-based estimates of diffusion anisotropy are unlikely to enhance the differential diagnosis of prostate cancer, and that's partly because of the apparent lack of a consistent correlation between FA and pathology, but also because we seem to have very big differences in FA between prostates. And possibly of more relevance to current practice, where we're thinking about ADC measurements and DWI contrast, this study suggests that because the FA is so low in most clinical size voxels, the ADC calculation and the diffusion contrast is not going to be strongly dependent on the orientation of the 3-direction diffusion weightings that are typically applied in clinical measurements. Okay, so briefly I'll follow up on this with a few ideas. So, should we conclude that FA is actually of no value for pathology assessment in the prostate? Well, if we're going to just use a basic mono-exponential DTI model, then the answer is probably yes. But what if we look at a more sophisticated model? So we've done this in a recent MRM paper where we compared 10 different multi-component models of the diffusion signal in prostate tissue. So the components of these models we looked at were what we call a ball, which is basically isotropic Gaussian diffusion, a tensor, conventional tensor, a Zeppelin, which is a cylindrically symmetrical tensor, and what we call a sphere, which is a impermeable spherical pore. So the nice thing about the sphere is it accounts for diffusion restriction and the dependence of the diffusion signal on the diffusion time. So we put these different components together in 10 different models, from the simple ball equivalent to ADC, biball equivalent to a bi-exponential, a series of different models that included the restricted sphere, and a series of models that included an anisotropic component, either the Zeppelin or the conventional tensor. We can say that anisotropy is important if we're modeling the diffusion signal in the prostate. Why aren't we seeing that on clinical scans? Well, the anisotropy appears as an important component when we've got a 2-component model, and the isotropic component in this case is quite significant in terms of the signal, so it would be acting as an isotropic background signal that tends to mask the actual anisotropy in the tissue. So it's possible that anisotropy may be of clinical value, but in order to be able to characterize it, we need to fit 2-component or multi-component models to our signals. So obviously this implies that we need to do a fairly sophisticated measurement with multiple b-values, multiple diffusion directions, and to get quite high SNR for that. Whether that's clinically feasible is yet to be ascertained. So finally, what can we say? Well, you might like to have a look at this recent review we described where we looked at the limitations of the current ADC-based methods for diffusion MRI in the prostate, and make some suggestions about how we can improve on these methods.